Hi, welcome everyone. My name is Dr. Meredith Russell from Ucsf, Pediatric Endocrinology. It's my pleasure to introduce Drs. Evelyn Mocklin and Dr. James Smith today to discuss fertility preservation options in patients with ovaries. Dr. Evelyn Mocklin is an associate professor of OB-GYN here at UCSF, and she's medical director of the UCSF Center for Reproductive Health. Her clinical and research interests include oncofertility, transgender reproductive health, and minimally invasive gynecological surgery, including treatments for congenital pelvic abnormalities. Dr. Mocklin has always had a strong interest in medically indicated fertility preservation in the pediatric population, and she took care of her first transgender patient a few years back as an attending and realized that she was unfamiliar with the unique needs of this population, and she dedicated herself to learning more and contributing to excellent transgender care and research. Dr. Smith is director of the UCSF Male Reproductive Health Practice, dedicated to providing outstanding reproductive clinical care, cutting-edge research, and improving access to reproductive care. He conducts basic science investigations of sperm physiology, sperm stem cells, and semen physiology, translational research focused on fertility restoration by means of testicular and stem cell transplantation, and clinical research into reproductive effects of targeted cancer therapies, such as tyrosine kinase inhibitors and mTOR inhibitors. Clinically, Dr. Smith treats birth-designated males with infertility and hypogonadism at the Center for Reproductive Health, and he specializes in the use of minimally invasive techniques for fertility preservation as well. He's passionate for caring for men with reproductive health concerns, and this began when he saw the tremendous impact male infertility has on the infertile couple. And his goal is to offer the highest level of male reproductive health care and service available so that the infertile males will have the best chance of achieving a pregnancy. It is my pleasure to introduce them to discuss fertility preservation options in patients with ovaries today.
Thanks so much, Meredith. So I will begin. I'll be talking about the options for peripubertal patients with ovaries, and then Dr. Smith, I'll hand it over to Dr. Smith to talk about the testicular and sperm side of things. So we'll definitely be, I'll try to be very careful with my time so that I don't run into Dr. Smith's time too much, and we'll leave some time at the end for questions. I have nothing to disclose. So just a couple of slides on the background and why we're talking about fertility preservation. Probably very much preaching to the choir here in terms of the very well-known fact that family building is important to a lot of people. And in fact, my entire field of reproductive endocrinology and infertility is essentially based upon that really strong desire to have fertility and to have biological offspring. This is well documented in the cancer population, and particularly in the cancer population, there's a large proportion of patients who make their decisions about their oncology treatment based on their concerns about their future fertility. It influences their decisions. And while we have a lot less data on our transgender folks, the limited data that we do have so far also show us very similar findings, which is that a large percentage of adults already have biological children, and a range of percentages based on the study desire future fertility. And what I thought was interesting in the trans adolescents is that a fair percentage of them already express that they desire future children, biological children, and a good percentage of them acknowledge that their feelings about this might change in the future and that they want to keep their options open. So we know it's important to people. A lot of study, again, a lot of data in the oncofertility space on the impact of cancer treatment on fertility. With people with ovaries, we know have a finite pool of follicles that depletes over time. And so the average age of menopause with ovaries is usually around age 50 or 51. And that sort of is the time at which the ovarian reserve and the bank account of eggs is depleted. Any chemotherapy, no matter how gonadotoxic or not, and any amount of radiation directed at the ovaries will decrease the reproductive lifespan of that person. And whether that person goes through immediate menopause or earlier menopause really depends highly on the age of diagnosis, as well as their type of chemo, whether they're getting whole body radiation or not, the dose of radiation, and probably some genetic sort of component in terms of susceptibility. But we know that no matter how little of a dose they get, we can still anticipate that their reproductive window will be shortened in the setting of cancer treatment. Radiation to the ovaries is more harmful to the ovaries than chemotherapy is. This is from the Childhood Cancer Survivor Study, looking at over 3,000 survivors. A couple hundred of them developed acute ovarian failure, which they defined as menopause within 5 years of their diagnosis, primary ovarian insufficiency. And they grouped it by the amount of radiation that they got directed at the ovaries. And you could see that the kids who got no radiation and just got chemotherapy, very few of them had acute ovarian failure, whereas 2,000 centigrade and above, a high number of them were in immediate menopause within 5 years. The impact of testosterone on future fertility is a lot less well known. There are a lot of questions still in this space. I am very reassured and inspired by the fact that there have been a lot more studies in the last few years. When I used to give these talks 5 years ago, I always joke that we would all quote the same like 2 studies. And so we know a lot more now than we did 5 years ago, primarily on whether there may be impacts of T on the egg number. And I'll go over that a little bit today. But the impact of T, especially long-term T, on quality, whether there's any potential impact on the future offspring, is this dependent on the dose that they're taking and how many years that they've been on it? Is that reversible? All of that is still very much unknown. And then, of course, the other category that we're seeing more, particularly from your department in terms of referrals to us, which we really appreciate, is the increasing number of kids that we're seeing who are on blockers and transitioning directly to T. And how do we counsel these patients and their families? What are their options? Even if we're able to retrieve an ovary or eggs from these kids, what is the quality of those eggs going to look like? Will they result in a live birth? Will there be any potential implications for their offspring? And how do you weigh the pros and cons of getting 12-year-old pre-monarchical eggs with 35-year-old eggs that have been exposed to 20 years of T? And how do we, balance those risks there? So a lot of still unknown. What we know so far, there have been multiple studies at this point looking at testosterone and the histologic findings on the ovaries. So looking at donated specimens at the time of bottom surgery, T-exposed ovaries compared to cis women who have donated their ovaries at the time of surgery for benign reasons. T-exposed ovaries do look different histologically. They have a thickened ovarian cortex, and they have more of these atretic follicles. More recently, the mouse models actually came after the human studies, but the more recent mouse models have shown the same thing, that there are more of these atretic follicles, but reassuringly no reduction in the total follicle count in the mouse models. So that's been reassuring. There are also studies looking at AMH, anti-Mullerian hormone, which is a really good marker, serum marker of ovarian reserve. It comes from these early pre-antral follicles from the follicular cells. The higher the AMH, generally speaking, the higher one's ovarian reserve. This one study looked at AMH levels in 22 trans men before and 16 weeks after starting T, and found that every single one of them had a dramatically lower AMH level within 16 weeks of starting T. And this is way more significant than what we see for like in the setting of, for instance, birth control pills, which we do see some suppression of AMH as well. So when around the time when this came out, this was really concerning because if it signifies a irreversible loss of follicles, then that would certainly be very, very concerning, as opposed to just very quick and very significant suppression of follicular genesis that may or may not be reversible. In more recent years, our group, as well as in the same year, we published a study, and as well as a group from Boston IVF, who also see a fair number of trans patients from the Fenway program. They get referrals from the Fenway program. And we both looked at, did a similar study where we looked at trans men who underwent ovarian stimulation for usually egg freezing. A couple of them went for IVF, compared to a cis cohort. And reassuringly, both of us found that even in the setting of prior T exposure, that there was no significant difference in the number of eggs retrieved or the number of mature eggs retrieved. So that would suggest that at least with relatively short-term T, that it doesn't seem to impact the ovarian stimulation or impact the ovarian reserve. The caveat being to this is that in both of our studies, on average, people were on T for just a few years. There was really no one that was contributing to these studies that had been on T for 10 plus years. And all of them had stopped T 3 to 6 months before undergoing this process. The other caveat is that it's good to know that the response to ovarian stimulation is good, but we don't know what the quality of it will be, because the majority of people were not making embryos and were not trying to conceive right at that moment. So what do we know about quality? We know that people can get pregnant, have gotten pregnant after taking T and even while taking T. And in those limited pregnancies and deliveries, it seems like obstetric and neonatal outcomes were no different, which is good. But in both of these Light et al. Studies, the majority of people were on T for less than 2 years, so very short period of time. So still very limited data in terms of the impact of T on quality. So for both cancer and transgender patients, all of our professional societies say until we have more data, fertility, the risk of infertility and fertility preservation should be discussed, as you all know. So in terms of options, we're going to talk a little bit about options for post-menarchal youth, which would be the same as what the options are for adults. And then we'll talk more about the options for the pre-menarchal, peripubertal kids. The gold standard by far, if they've gone through completed puberty, is egg freezing, oocyte cryopreservation. If they are getting specifically pelvic radiation, then we can also move the ovaries out of the pelvic brim so that they're outside of the field of radiation. And then the other option would be ovarian tissue freezing, which I put an asterisk on because if they've completed puberty, by far the ideal would be to freeze eggs as opposed to freezing tissue because of the limited outcome data. And we'll go over that in the next, when we talk about the pre-pubertal kids. Now, a couple of things that we certainly consider is that's different from like our standard egg freezing patient is that these patients are really young. The types of things that we're doing, the types of exams we're doing are uncomfortable for them and for their guardians. It's a lot of decision-making by their guardians about their future, trying to preserve their future options. It's a huge lag time between now and when these patients may want to build their family. And there's just a lot of unknown about the long-term outcomes and what the options will even be in 20 years, because we've seen so much change in the field of REI and in IVF. We just don't know what the science will look like in 20 years. The key thing here that I'd like to emphasize for all of you is as early of a referral as possible is key. It gives us as much time as possible to help navigate the decision-making process, financial, insurance, and also to avoid having fertility preservation be seen as a potential hurdle or block, which I do sense that is often like the impression I get from the transgender kids that I'm seeing, is that they see it as like an extra step that they have to do. And I always emphasize that they don't have to undergo anything, but we always want to give them the space and the time to make that decision and have those family conversations. Now, egg freezing, as many of you probably know, is very safe, very effective. Again, the gold standard in anyone who has completed puberty and any adult. It can be started immediately, so we don't need to wait for someone to have regular cycles or to wait for their period. We have a lot of data on our cancer patients where we do what we call random starts. So we can start at any time in their cycle. And it only takes 2 weeks to complete. So we can start the day that I see them and we would be done in 2 weeks. And it can be frozen probably indefinitely. There's no maximum that we are aware of in terms of how long they can be stored for. Some concerns is if it's not covered by insurance, or not at least covered by insurance upfront, it's certainly very expensive. And depending on their family planning goals and their number and their age, some patients may need to do this multiple times to get the number that they would ideally have, which we may or may not have the time or resources for. And we want to be mindful of, obviously, the side effects and the mental health aspects during this process. Just really quickly about the process itself: daily sub-Q injections, self-administered at home for 2 weeks. Lots of appointments during that time in our office to monitor their response. The default is transvaginal ultrasounds. I would never do a transvaginal ultrasound on a child who has never inserted anything in the vagina, or who doesn't want me to. And so we can do transrectal ultrasounds, which give us essentially a very similar view to transvaginal, and very well tolerated, or transabdominal, which gives us a really suboptimal view of the ovaries. But I always have that conversation with the patients and the parents, and we don't want to have any of these steps be a potential deal breaker for them. So we'll always try to accommodate what their preferences are, acknowledging, the limitations of each of those processes. The retrieval is done under anesthesia, almost always done transvaginally, but if they can't because they've had bottom surgery or they've had radiation in the pelvis, or their ovaries have been moved, then we can do it transabdominally as well. And it only takes us 30 minutes or less. Almost no one needs any pain medications to go home with. So very safe, very quick procedure, and really very, very low risk. The main thing I would highlight in this patient population is the risk of OHSS, ovarian hyperstimulation. Given their young age, they tend to have a really high egg number. Trans patients have there's a higher prevalence of PCOS, polycystic ovarian syndrome, amongst the trans population, and so they're already at higher risk as well. So we watch them really carefully. It's very, I would say less than 1% in our hands, given how closely we monitor them and the things that we do to try to mitigate that risk. Couple other things to consider is for our trans folks, do they need to stop T? The studies that I refer to, including ours, on average, they all stopped it for 3 to 6 months. Boston IVF, at least at the time, required this. So this was a requirement to stop for a minimum of 3 months, and or they had to have gotten their period back, and or they had to have natal hormone levels before they were able to proceed. In our clinic, I never required it. Oftentimes it was a sort of discussion that the referring provider had said, Ari, I would probably want them to discontinue it. And so they were already off of their T by the time they saw me. We don't have any data that this is necessary. There's no guidelines on it. It is very much arbitrary as to whether we say 3 months or 6 months or 1 month, and acknowledging that's likely to increase dysphoria if they have to stop. And so I don't require that people stop. The first case that was reported was last year, where there was a patient who continued their T throughout their stim and they got a good number of eggs. You'll note that they were only on 25 milligrams, which seems low compared to what I've seen here. Our patients, we just published our 2 cases where they were on more typical doses of 60 to 80 milligrams weekly of T. They continued it throughout. We talked about risks and benefits, unknowns and knowns. They elected to continue, and they also responded appropriately in an appropriate period of time on an appropriate amount of medication. So of course, we don't know the quality of these eggs because none of these patients were ready to use them, but the proof of concept of being able to continue the T and have high levels of circulating testosterone and still be able to get mature eggs just provides our patients just yet another option to consider. So not a deal breaker if they don't want to come off of T. Other things that we think about for both cancer and trans patients are things that are using aromatase inhibitor, usually letrozole. We have a lot of data in our breast cancer patients that using letrozole does not impact their outcome. So we still get the same number of eggs using letrozole or not. It just decreases their circulating estradiol levels. That's helpful if we're worried about VTE risk in the setting of malignancy or recent surgery. It keeps the endometrial lining thinner than it would be otherwise, which limits their withdrawal bleed, which is helpful for both the cancer folks and the trans folks. And certainly for the trans folks, anecdotally, I do feel like it does help with limiting sort of the mental health and dysphoria experience during that process. So we talk about that. We take precautions to minimize the risk of OHSS. And again, the alternatives to transvaginal ultrasounds. So in terms of options for pre-menarchal patients, so aside from moving the ovaries, which really only would benefit the people that are getting directly pelvic radiation, right? It doesn't help for total body radiation. It doesn't help for high doses of chemotherapy in preparation for a stem cell transplant, for instance. Previously, the only option was to freeze tissue. We laparoscopically remove an ovary, we cut up the tissue, cortical tissue, and we freeze the strips of tissue. The benefit is that we can do that. There's no delay, it doesn't take 2 weeks. We can preserve a large pool of follicles. The cost of the freezing is very low to the patient because most are still under research IRBs, although the surgery would have to be covered by insurance. And it doesn't require any hormone injections or ultrasounds and that sort of thing. The problem is it requires laparoscopy, so you do need that, especially in a pediatric population. The risks of surgical risks are certainly something to consider. There are only about 20 clinics in the country that offer this. So even in our area, we get tissue from Kaiser hospitals, for instance, couriered to us for us to freeze. And the main limitation is that it's still very, very much, the outcome data is very limited. There's about 130 live births from cryopreserved, thawed, and then subsequently transplanted tissue. And all but one of them that I could find are from adult tissue. And so this is like, we don't know what it would look like to take ovarian tissue from a pre-pubertal, let's take a 9 or 10-year-old, whether they would function the same way as the adults. And even if they did, the 130 live births, it's not very many in the last 20 years. All of the live births have come so far from putting the tissue back into the pelvis. So that requires another laparoscopy. There are some benefits to it. It allows, if the person has retained their reproductive organs, it allows for potentially spontaneous conception. But obviously many downsides to that. Another laparoscopy to the pelvis, it may or may not work. You may have to do it multiple times. They may or may not want to put it back into themselves. More recently, the field, we've explored putting them elsewhere. So here's a picture of putting it in the forearm. Recent years, that hasn't worked very well. The vascularity is not very good. So there's more studies looking at putting it into the abdominal wall. Also many benefits to that. You could do essentially IVF and monitoring and retrieval of the tissue and transplantation of the tissue without general anesthesia. but there are no live births that I'm aware of so far in heterotopic transplantation. Now, as I mentioned, transplantation may not even be possible or desirable, right? One thing is, in many of our pediatric patients with cancer, they're hematologic cancers, and there is a risk, theoretical risk, but not a risk that we're probably willing to take, of reintroducing the malignancy if we transplant the tissue back into them. They may not have their reproductive organs, they may not want to have come off of their T, their trans, in order to allow for the graft to work. And it requires multiple procedures to do it. And the max reported time that the graft has lasted has been 7 years. So you may need to do it multiple times. So the future of this field in terms of ovarian tissue freezing, and I want to wrap up in the next couple of minutes, but I do want to tell you something really quickly. In the next few slides is the future direction would be ideally, and what I'm telling parents now for like a 10, 11, 12-year-old is, we do hope in the next 20 years that our field, the science will advance to the point where we can do in vitro growth, where we can extract immature eggs, grow them in the lab to maturity, do IVF, transfer to the patient, partner, or surrogate. But it's never been done, and it's been studied for several decades now. The first successful mouse live birth was in 1996. And so there's a number of mouse models now, but it's not yet been done in a human model. And we already know, for instance, in IVF, just 2 extra days of culture media increases certain things like monozygotic twinning. And so to do in vitro culture for several months, even if it results in a live birth, has really unknown effects, especially epigenetic sort of effects on the offspring. But this is where the field likely will be going in terms of ovarian tissue freezing. It's not very practical to have to keep transplanting the tissue back. Now, prior to this 2019, we were saying, okay, to the parents, this is what we're going to do. We can freeze ovarian tissue. It may or may not work in the future. This is really our only option. Until 2019, when this group in Pittsburgh was the first to show that they were able to retrieve mature eggs from a patient who was on blockers. This had never been shown before. They were TN or 2, had been on blockers, about to start T. It took 30 days, which is more than twice what we typically need. And of course, they only got 4 eggs, which is not very good, but never been shown prior to this. And we never thought it would be possible that you could get mature eggs from an ovary that hadn't completed puberty yet. Since that time, we've had a handful of cases around the country, including one here, which we have not published yet because we're waiting for some additional information first. But we've had 4 other cases that I am aware of around the country that have attempted this. We've all gotten more eggs than that case initially, and in a shorter period of time. And so this is very reassuring. And now we are offering this to people on blockers if they're about to start T as an option that we can attempt. We still don't, and we won't have any data on the quality of these eggs, the fertilization potential. Will it result in a live birth? We're not probably going to get that information for a long time. But again, sort of just as another option, and keeping, certain things, being able to offer patients and their families another option is very helpful. And it's not limited to the transgender folks. I mean, we can offer this to our cancer folks. It just had never been attempted even before, because usually in the cancer setting, we are so time limited, so urgent, that we can't necessarily afford to say we're going to try 30 days and we may or may not get some eggs. And we usually don't have that kind of time. But certainly for trans patients your patients who are on blockers, or for whatever reason have more time that we can potentially consider this, it's certainly something that we're going to offer more and more. Really quickly, before I wrap up, I just want you all to know that in the state of California, California was the 8th state to enact a law, sign into law, to mandate fertility preservation coverage for those in whom iatrogenic infertility is anticipated. So it includes surgery to remove the ovaries, radiation, chemotherapy, and gender affirming treatment that there's like a couple of like exclusions, including Medi-Cal, but this went into law in October of 2019. And so many of our patients qualify for this and should have their insurance cover it. The problem we've run into still is that it's state by state law. And so a lot of insurance companies, and is relatively new, and then COVID hit in 2020. So a lot of insurances are still unfamiliar with the California state law. And of course, many of our patients have Medi-Cal. So it's still been a struggle to get insurance on board, but we're helping patients with submitting appeals and that sort of thing, and getting coverage. And certainly, again, that goes back to early referral is key, because if we have more time to help figure this out, the better. So that wraps up my part. I will hand over the talk to Dr. Smith to talk about sperm.
Great, Dr. Mocklin, thank you so much. And I really appreciate being given this opportunity to speak today as well. Many of the things that I'll talk about in my portion are essentially really analogous to what Dr. Mocklin was just describing in her portion. And I'll be describing essentially fertility preservation and some at least future potential for restoration for both children, adolescents, and young adults. So I serve as an advisor to Fellow Health, Posterity Health, and Inherent Biosciences. And essentially, it's a big deal, particularly for these people who are exposed to chemotherapies, radiation therapy, that fertility is often a top concern, these patients. From a cancer standpoint, more and more patients are surviving as oncology does a better and better job at treating these patients. And so fertility preservation and potentially restoring fertility becomes more and more important. So I opted to focus much of the conversation this next 25, 30 minutes or so on different cases. This was a patient, 25-year-old patient, who had a single orchiectomy and didn't bank sperm at that time, underwent bleomycin, topicide, and cisplatin. Patient's partner is 24 years old and came in to me to see what could we do from a fertility standpoint. The patient had signs of testicular impairment based on this very high FSH level, very high luteinizing hormone level. And the semen analysis showed that there were a few non-moving, essentially dead sperm that were there. So what are some of the treatment effects of cancer from a male reproductive health standpoint? So it can cause a zero sperm count or azospermia. It can cause oligospermia or decreased numbers. It also can cause impairments in the quality of sperm, just functional impairments of the sperm's ability to do the jobs it needs to do. For some patients, it can impair their ability to produce a semen sample, and that really is based on certain spine and pelvic surgeries. And particularly in the case of radiation, it can affect the testicle's ability to make testosterone. Some of the lower risk treatments I've listed on this slide, but the main point that I wanted to make is that really there's no zero risk chemotherapy, and there can be really profound impacts for some patients and not very much impact in other patients. So as much as you can bank sperm ahead of time, the better. One of the areas that remains very understudied is the effect of targeted cancer agents on reproductive health. In this particular slide, this highlights the potential impact of tyrosine kinase inhibitors on sperm function. Essentially, tyrosine kinase and phosphorylation on this particular residue is important for several sperm quality sperm functions, including the ability of the sperm to become more flexible and move vigorously, this process of capacitation, as well as the ability of the sperm to bind to an egg and induce fertilization. And tyrosine kinase inhibitors can impact this, but there's really not very much data that is known, and it's not often studied, this nor other targeted cancer therapies. Some of the higher risk chemotherapeutic agents I placed on this list, including cisplatin, ABVD, and these therapies can induce azospermia in significant numbers of patients. Many of these patients will recover at least some spermatogenesis, some sperm production over time, but there's pretty high risk of fertility impairment. The highest risk agents are the alkylating agents, some of the mustard agents I've listed on this slide. And many of these patients can have permanent zero sperm counts, but that's not always. And I just recently saw a patient who had high dose of all of these agents as part of his treatments and ended up having a significant number of sperm afterward and was able to conceive spontaneously. Radiation, just as in the female gonad, it's a big deal and it can affect fertility pretty profoundly. The dose is very important for patients who receive more than about 3 gray. The chance of azoospermia is almost certain. From a testosterone standpoint, as the exposure to the gonad goes up above 20 or 30 gray, the chance of having permanent low testosterone, in addition to that 0 sperm count, is pretty high. So what is it that we could do for this particular patient? This patient was producing semen samples that had some sperm, but they're all dead sperm. So we can't use those sperm for in vitro fertilization. So the standard of care from having a patient have their own gametes would be to start out typically with banking a bunch of samples and see if there were, at some point, there were a number of sperm that were available in that sample, or to pursue a surgical approach. And so many of these patients have this Sertoli cell only or maturation arrest appearance histologically. And what I'm looking for surgically are small pockets of sperm production. The other approaches are to use a sperm donor and do intrauterine insemination or adopt. This microtessi or microsurgical testicular sperm extraction is a procedure that I will either do separate from an IVF cycle or at the same time as an IVF cycle. For a patient like this, I generally do it not in sync with in vitro fertilization. Typically takes about 2 hours to do the surgery, and the lab is looking through all of these seminiferous tubules that I send to them and looking for sperm. And if they find sperm, then that can be used down the road for in vitro fertilization. Overall, when you look at patients in this group, in this cancer, been exposed to chemotherapy group, the type of chemotherapy is really critical. For testicular cancer patients, the success rates are often much higher and really purely due to the kinds of chemotherapy that they're exposed to. So another patient I saw a few years ago was a 19-year-old who had had a right orchiectomy and had non-seminomatous germ cell tumors, had 4 cycles of BEP. Then also, because of the tumor spreading to his retroperitoneum, had also had a retroperitoneal lymph node dissection. And this particular treatment is basically a treatment in which extensive lymph node tissue is extracted. Now, the schematic that I've placed on this particular slide highlights templated approaches, which are nerve-sparing approaches, but this patient had not had that. The patient had a new left testicular tumor and needed to have an orchiectomy. So the patient was young, desired future fertility, had not banked samples before, but was unable to produce a sample. So looking at this patient's labs, the labs were roughly normal. The FSH was a little bit elevated, but we had no way of knowing. The patient was unable to produce a semen sample. So what could we do for this patient? So we could do what's called an oncotessi, where I'm surgically getting sperm out at the time of doing an orchiectomy, or I could do electroejaculation. EEJ is really cumbersome and time consuming. An advantage is that it can induce some patients to ejaculate and you can get more sperm, enough sperm to do intrauterine insemination. So what we opted for this patient was to do an oncotessi. I removed the patient's testicle and then was able to dissect out the epididymis and some normal appearing testicular tissue not associated with the cancer. And this was the sperm that we saw in those samples. And so this was frozen. And this patient down the road has an excellent chance of being able to conceive with in vitro fertilization. So what is it we do today for our post-pubertal patients? Essentially referring to someone who's expert in the areas and banking sperm, considering testicular sperm extraction, like is the case that I just presented. In the case of when you're preserving sperm like this, it requires either intrauterine insemination or IVF. So from a practical standpoint, for IUI, this is an approach that requires lots of sperm. So you generally need at least 5 million moving sperm for this to be successful. In the whole grand scheme of things, it's relatively affordable, but still very expensive for many of our patients. And the chance of success depends a lot on partner's age and health. Roughly 15 to 20% chance of pregnancy. There are many things that cause that number to go up or go down. From an IVF standpoint, you essentially just need as much sperm as a partner has eggs. Generally, as you go through this process, there's about a 50% chance of getting pregnant per embryo transfer. And again, many things can affect this number to go up or go down. The cost is pretty expensive and generally not covered terribly well by insurance. So from a practical standpoint, some of the strategies that I'll employ when I'm talking to patients are talking to them about their reproductive goals. In the case of transgender patients, talking to them about with whom do they see themselves down the road. And it's often it's tricky for younger patients. They don't know necessarily whether they're going to be with a patient who has an ovary and uterus or not. But I typically will try to strategize toward giving the patient as many opportunities to do intrauterine insemination as possible. Or if for patients who have lower numbers of sperm, really trying to strategize for how many IVF cycles they can do. But this is part of the conversation that we'll have when I see these patients. So in general, the fertility preservation guidelines from our societies essentially is that we should discuss the risks of fertility problems with any cancer patients, or really any patients who are exposed to fertility threatening treatments, including our transgender patients, and refer patients who are interested to reproductive specialists. Now, if here at UCSF, if you wanted to make this happen, you had an inpatient, you'd essentially request a urology consult. Our residents will come see your patient. Generally, we'd order the required FDA labs for freezing semen samples. There'd be a consent form in terms of what to do with the sample in the event of the patient's death. And that's done by our nurse practitioner, and that's often done virtually. Patient has to produce a sample in the hospital, and then either courier or the family would transport that sample over to the Center for Reproductive Health, which is over on Illinois Street. And then later, after things settle down, that's when I'll have a consultation with the patient, the family, about their results. As an outpatient, the referral is to urology, just highlighting fertility preservation, and we expedite these referrals. My nurse practitioner will see this patient. This is David Dunca. He'll order the labs, get a consent, get the sample, and then there'll be a consult with me to discuss strategizing about how many samples to bank. The challenges really are that these are both really time consuming. So as Dr. Mock-Lin pointed out, the sooner that these patients can be referred over to us, the better. It just gives us more time to work through all the issues, trying to appeal the costs and get things covered and help to preserve fertility as best we can. So listed on this slide are reasons why people don't do it. It can be that treatment needs to begin too soon. It can be too expensive. Or in many places, I mean, we're fortunate at UCSF to have robust expertise and infrastructure to bank, but in many places that's not the case. And for some people, or for some doctors, belief that it's not necessary to do it. In the case of pediatric patients, as we'll talk about in a few minutes, that it's an experimental approach. Many patients do experience significant regret, though, when they don't at least have the opportunity to preserve tissue. So what can we do about making this easier? So a few years ago, I'd led a team that essentially developed a mail-in process for a semen analysis. And essentially we took fresh samples, developed a system to basically keep those semen samples alive for a longer period of time, and just measured the decline in motility over time and compared an observed semen analysis and that we measured at T0 and a predicted semen analysis based on an algorithm that we developed. Did this on many semen analysis before we came up with an approach that worked effectively. And what we saw was that there was a slow decline in motility over time. And this is what really enabled us to develop a semen analysis where we can get a sample a day after production and accurately predict back to what a baseline semen analysis would be. We found for these patients, as we checked their semen over time, that there was a predictable linear decline in motility, which is very different from a standard semen analysis, semen sample that you just leave on the counter. The motility declines rapidly and often unpredictably. And we found this, our predicted semen analysis was very closely correlated with what we actually observed at baseline. So this led to work that we presented at the American Society of Reproductive Medicine, where we're demonstrated some of our preliminary results. And it wasn't really quite as consistent yet. And what we overall, when we looked at all patients in this group, we saw about a 0.6% decline in motility over time. But really with this essentially this mail-in approach, what we found in the preliminary data was that there was some patients who had a predictable decline in motility, kind of like I would expect from the earlier semen analysis study, patients who had no decline much at all, and also patients who had a precipitous decline over time. Over the intervening year and a half or so, as we've continued to work this out, I believe that much of the problem was really methodological. There are issues about just how you calculate the number of moving sperm in terms of how you do some dilutions and other technical parts of the lab. And so since then, this is now a clinically available approach. And one of my patients who lived as a transgender patient who wanted to bank sperm prior to beginning spironolactone and estradiol, we talked about options. The patient lived far away from UCSF, and we opted for a mail-in approach. So when the semen sample arrived, it was about a day after the patient had produced the sample. The predicted number of sperm the patient would have had was about 250 million moving sperm. This was based on that algorithm. But the actual observed number of sperm was about 209 million. So about a 15% decline over time. And that's kind of more or less what I'd expect after a day of going and shipping in this kit. So from a practical standpoint, this patient essentially was able to produce a sample at home and get basically 4 IUI cycles worth of sperm, or many more likely than that, IVF cycles. Or if the patient had come into us in person, it would have been about the same situation. So for me, this is really encouraging. And we continue to investigate this process and to see how well it worked. So shifting our focus to the pediatric side of things. So what can we do about little kids who are exposed to chemotherapy? So this patient with a brain tumor had undergone resection of this tumor, and because of the tumor type, was about to be exposed to lots of chemotherapy that would likely hurt future spermatogenesis. So his parents asked me, what can we do about this? And is there anything that we can do to preserve this patient's fertility? And so it is possible, as we talk through this, it's possible that you could take this testicular tissue out and potentially either grow sperm from stem cells in vitro, or potentially take those cells out and transplant it back to the patient. This pediatric testicular spermatogonial extraction, this is a pretty simple to do approach. We do this through a protocol we have here called the PD Life study. I do it in conjunction with our pediatric urologist, both here and at Children's Hospital Oakland. Unfortunately, we cannot do it yet at outside facilities, outside of UCSF. Also, our pediatric general surgeons, both here and at Children's Hospital Oakland, can do this. There are important ethical considerations that I'll at least just touch on briefly. Typical considerations for any procedure that we do in terms of respecting an individual and the family's right to make their own decisions, doing good for patients, not doing harm for patients. What I wanted to just spend a few moments on, though, was the tissue ownership and consenting part of this. So some patients, unfortunately, they do die after beginning chemotherapy. And what are the options that should be available? Typically for our adult patients, there are 3 options that a person can consent to. They can either discard the sample in the event of their death. The sample can be given to their significant other or spouse. A patient can designate somebody to have this tissue, or the sample can be used for research and then later discarded. What we've decided upon, however, is to only offer 2 options for pediatric patients, and that's to discard the sample or do research and then discard. And the question is really about whether or not it's something we should allow to the next of kin to have access to this tissue. This first came up for a patient of mine who was about 3 or 4 years old, who had Wiskott-Aldrich syndrome, ended up having a stem cell transplant for this, and then died as a result of the complications of that treatment. And mom called me and we spoke about whether or not she'd have access to the tissue. When you think through that, there are so many questions that come up in terms of, where do you get the eggs? Would it be the mother? Would it be an egg donor? From the child standpoint, can we grow sperm? Would the child want to have a offspring with this particular kind of situation? So there are many considerations. And in this case, we believe it's only really appropriate to allow discarding or researching for the sample before discarding. So the family asked me in this case, what could we do in the future? And there are two ways that we could possibly use this tissue. We could either transplant the tissue back to the patient down the road or grow it in vitro. In the case of the transplantation approach, this has been done actually since the mid-1990s in a variety of different animal species. Was done in rhesus macaque and published in 2012. This was work done in Pittsburgh. And they demonstrated that you could take this testicular tissue out, you could inject it into the central portion of the testicle, and you could see spermatogenesis. So over the last few years, we've been doing this in my team and doing this in a series of different types of both animal testicles. And then most recently work that we published was looking at cadaveric human testicles and see if we could inject tissue, these cells, into the middle of the testicle. And we found that it is a practical approach, something that I can do with the residents and could do it as a practical approach. This has never yet been done in humans, but we are inching our way closer to being able to do this in people. The work that's farthest along continues to be led by Dr. Kyle Orwig in Pittsburgh. And what he demonstrated was with a prepubertal rhesus macaque monkey, taking testicular tissue out, subjecting that monkey to chemotherapy, high dose of chemotherapy, and then transplanting these small fragments of tissue under the skin of the back and the skin of the scrotum. And what they observed over time was that these little nubbins of tissue grew and actually had spermatogenesis in them. They were able to take the sperm out and do in vitro fertilization. And indeed, they were able to induce a healthy pregnancy. And this is a baby girl monkey who's healthy and named Grady. Now, again, this approach, in contrast to the approach I just showed you, is very straightforward. And surgically, to take these small fragments of tissue we've been storing for the last 6 or 8 years is very straightforward. We've probably enrolled about 40 patients in this study so far. And as these children get older, I've had a couple of patients now come through and at least talk about whether or not this is something we could do. Now, flipping to the other side of the coin, this is much more relevant from a transgender standpoint. And you take this testicular tissue, and could you induce this tissue to grow to sperm? This has only been done in mice. About a decade ago, it was successfully shown that you could take newborn mouse testicular tissue out, you can induce it to grow to sperm, do in vitro fertilization, and have healthy mouse pups. There is work that's ongoing, but there's as yet been no successful pregnancy or really even getting close to that yet in people. So in terms of some of the challenges we face, rapid referral, consenting, all this coordination, it takes time. Getting patients to us as quickly as possible is really important. We wonder about how big of a biopsy to take when we're doing these pediatric biopsies. Right now, I err on the side of taking not very much to try to minimize harm to patients, but some would advocate that we should do an orchiectomy and take more testicular tissue. And perhaps that's what we'll come to as our expertise expands. We need to learn how to grow these spermatogonial stem cells to sperm. And this remains a goal of the work that we do as part of the Pediatric Life Study. And I think that mail-in cryopreservation has a huge potential for us breaking down some of the barriers to patients as we continue to make this practical. So some of the take-home points, our collaboration between all of our groups is really, really important to make this work and provide the best care to patients. Referring patients over to us early is really, really important. Banking sperm or tissue prior to therapy is really the best situation. And then it is possible for us to bank testicular tissue for some patients. And really often it just requires a lot of discussion with families and patients to come up with the right approach. These collaborations are really, really critical. So again, with that, thank you so much for giving me the opportunity to speak with you all today.
Well, I want to thank both you, Dr. Smith and Dr. Mocklin, for this excellent and informative presentation. You're providing excellent clinical care for these patients, but also doing really cutting edge research. I found it fascinating, in particular, the work you're doing, both of you, for achieving fertility preservation for early pubertal stage children or pre-pubertal children. That's just amazing. So we're going to open up the forum to questions now. So anybody who does have a question, please go ahead and type that into the Q&A box, and then we will go over questions. We have about 5 minutes left for that.
While people are typing, maybe I can ask the first question to Dr. Smith. Why this is relevant to the whole issue of trying to restore fertility in these patients, because as you pointed out, there's oftentimes a very reduced sperm count, but it just kind of makes me wonder why do we need 250 million sperm? There's only one egg. I can see maybe you need 10, 100, maybe even 1 million, but 250, it just seems very wasteful from a physiological perspective. And just curious about your thoughts about that.
They're very inefficient, right?
Yeah, they are very
inefficient.
We're actually, we are pretty inefficient as far as sperm producers relative to other animal models. In terms of like mice or rats, they make billions of sperm pretty routinely. But you lose a lot of sperm just during sexual intercourse. You lose a lot of sperm within the vagina, the cervix level, before you even get through the cervical mucus and up into the uterus. There are lots of errors within sperm itself that are not going to allow an individual sperm necessarily to fertilize an egg. So it'd be fantastic if you could just have 100 perfect ones to get in there, get right where they need to be, and find a perfect egg. But I guess it's that redundancy part.
Thank you. So we have a few questions that are actually in the chat section here. So I'll go ahead and read them out. One is UCSF going to be a site for pre-pubertal ovarian tissue cryopreservation?
So we have been offering this. We're one of the few clinics in the probably even West Coast that freezes ovarian tissue. It's very labor intensive for our lab. So we have a couple of things that we have to consider and coordinate with whoever's doing the surgery. And they have to be the first case of the day. We need to get the tissue to us in sometime in the morning because it takes our lab 6 to 8 hours to process the tissue and freeze. So, but we do currently do that. So we do get tissue from UCSF affiliates as well as like Kaiser and other hospitals, because it's not a service that many other departments and clinics offer. So we do freeze, and part of the consenting process is where we retain some, I don't remember exactly what percentage we wrote on our consents of like some portion of that tissue may be reserved for future research use, so that we can, as we get closer to being able to do some of that in vitro growth work to extract primordial follicles and mature them in vitro, that we would need some tissue to do that research on. And then the question about covered by insurance, it's tricky because even with SB 600, which mandates fertility preservation, it's written as egg and sperm. So even people who want to make embryos may or may not have that part covered. So if they're partnered and they were intending to conceive with that partner and they want to make embryos, that's still unclear whether each insurance company can sort of determine whether they would cover that part. And particularly ovarian tissue freezing in a pre-pubertal person is still very much experimental, given ovarian tissue freezing in general is not experimental because of the live births that have been shown, but those were in adult ovaries. And so I think it would be tough to argue until we have a lot more outcome data that insurance has to cover it. Now, the good news with ovarian tissue freezing right now is as long as the surgery is covered, so usually you try to time the surgery to something else if they need surgery for whatever other reason, then the cost to the patient of freezing the tissue is relatively low. I want to say under $1,000.
Along those lines, one of the practical tips, many times patients just want to talk, or their families just want to talk about the risks and, how to plan down the road. And essentially what I'll do is I'll code the visit as whatever underlying problem they have. So when you send patients over, if you check off infertility, insurance often puts a block up. But if you say this is for leukemia, or this is for thrombocytopenia, or some other kind of problem, then insurance does a much better job to allow us to provide a consultation. And most insurances allow that.
Thank you both. I think we're at the end of our time today. I did want to just mention for everyone that it's routine care in oncology and gender clinics to discuss fertility preservation options with their patients and refer them over. And I want to thank you both for providing such excellent care and coming to talk with us today on this topic.
I would just like to thank all of you as well, Dr. Russell, Dr. Macklin, and Dr. Smith, for really stimulating grand rounds. And thank everybody for participating today. We'll see you at the next pediatric grand rounds. Have a good rest of your week.
Thank you.